We're going to now hear before lunch from Deneen Vojta from UnitedHealth Group, sorry, and she's going to give us an overview of the paper that Reed was talking about earlier, and this is the paper called Mapping the Future of Genetic Testing and Molecular Diagnostics, a payer's perspective on integrating personalized care into clinical practice. Thanks, Deneen. And I think you may have to start without your slides, I'm sorry.
So, first of all, good afternoon. And I can't decide what's the worst position for speaking. Is it right after Reed? Or is it during lunch? So either way, here we go. This is the paper, by the way, and it's outside. There are some extra copies, but there is actually, today I heard a lot about interest in particular data. We expected actually to take about 3 months to put this together. It ended up being 9 months. It was a lot harder than we thought, but there's a lot of very specific data in here, and if you want additional copies, you can just go to the UnitedHealthGroup.com, click under Health Reform, and then under Research, and you can print your own copy. But there's a lot of specific data. I'm just going to highlight some of it here for you today. So, again, we want to thank you for the opportunity to present what I'm going to call real-world data. I thought it was interesting when I looked at the invite list. Are there any practicing family doctors in the room? Do you do anything else except family practice? Oh, that's great. So it's really important, that, as we talk, sorry, so good old bread and butter family practice. I'm a bread and butter pediatrician. And so, do you want to do that? So we are going to talk about, again, our real-world experience in our UnitedHealthcare book of business and present some data. Well, I think what you're seeing sort of in the larger picture is that health plans increasingly are becoming what we call care system animators. So that is, if you think about who we are, we have vast information on population health. We have a lot of data on clinical performance. Our technology and computing power are equal to many of the sort of IT major companies. And equally important, we, on an everyday basis, have the ability to incentivize both consumers and physicians. So we're in a unique position to partner with people like you and add to the conversation on a number of issues. And today it'll be genetic testing and molecular diagnostics. So what do we know? Well, like Roger was alluding to, I changed this on Wednesday when I woke up, and although Roger probably read his in the New England Journal of Medicine, I read mine in the Star Tribune on Wednesday morning, and I woke up and the title was, Scientists Report Setback in Customized Cancer Care. I said, uh-oh, I know I'm coming here in a week. I better read this and see what's going on. And it is concerning. That New England Journal of Medicine article and from the UK group, basically they found intra-tumor heterogeneity, both poor and good genetic expressions. That's concerning because we thought we knew that one, and in fact, we don't know. So now what I'm going to present today is just descriptive data, and this I think we do know. And we're going to talk about how widely genetic testing and molecular diagnosis is being used. And by the way, why this took 9 months, this data was hard. It was really hard. There's such little specificity because of the fragmentation of both delivery and financing, but B, because of the coding issues and the lack of transparency in what we just use in our world, and that's claims data. So how widely is it being used? And what do real consumers and real physicians think about the genetic testing and molecular diagnostic space? And lastly, what do we have to do to ensure that patients and society at large can benefit from all these advancements? As you know, Francis Collins coined hope, not hype. With our consumer survey data, that's what we found. I called it cautious optimism. So if you look at our data, and again, there's a lot of detail in the publication itself, good news. 75% of consumers think that with this kind of testing, doctors will both be able to prevent disease and help diagnose early. And that's really good news. Only about 6% of consumers think that they've had a genetic test or molecular diagnostic in the last year, but they think about 10% of their family members may have had one. So interesting. And the majority of people, overwhelmingly, think that that again, molecular diagnostics and genetic testing will help advance care in the future. But I think this is where hope is eternal, springs eternal, that only 4% of people think they'll need the test. So, so it's great that the testing is going to help people with cancer, but it is sort of interesting from a psychological perspective how many of us says, well, it's not going to be me, it's going to help all you. So that's exactly what we saw. And the cautious part, so that's the optimistic part. The cautious part came overwhelmingly was people were concerned about their doctor's ability to interpret the results. And that's okay. That's what, I think we all are concerned about that. And less so, but certainly came out, are the issues of privacy and non-discrimination. What also you feel, this is really just a feeling in the data, is that people didn't understand the protections that are already out there. So it's not that they didn't trust the HIPAA and GINA, et cetera, it's that they didn't know about it. What do physicians think? Again, cautious optimism. The majority of physicians, and this is interesting, only physicians think about 4% of people in their practice have had a genetic test. In 5 years, they think that number is going to be 14%. But 75% of them said they could think of somebody in their practice who would benefit from a test today. Interesting. So why aren't they getting these tests? Well, that's sort of what I'm going to go back to, the cautious part. Interesting, 40% of physicians, and this is higher with specialists. With specialists, it was 50%, are very concerned with the validity of the test and the clinical, or as the person used, and I love this new, personal utility of the test. So I think that we need to answer those questions for physicians. And the second one was their own personal knowledge. Only 28% of physicians came out and said they're fully knowledgeable about how to interpret genetic tests and then use those for their patients. 2/3 of physicians said they really want better materials. As Reed said, we got to do better than the brochures. We really need to help physicians get those messages across. Oh, okay. It's not been up? How am I doing? Okay. I love that. I have to ask, okay, well, I'll get that later. So, now, interestingly, I love question and answer, but I shouldn't do that. I only have 10 minutes. So, of oncology, perinatal neonatology, or perinatal newborn, pharmacogenetics, or infectious disease, which of those do you think the physician groups thought that they did a better job with understanding? Was it oncology? Let's just take a vote. Oncology. You're right. Prenatal newborn screening. No. That was in the, right. Isn't that interesting? Maybe there weren't enough pediatricians in the sample group. Genomics. Yeah. Higher. A little surprising, but again, that's the beauty of surveys. This is what real physicians said. And of course, infectious disease. And that's why another comment someone said, it seems to me that in the molecular diagnostic area, it's no longer genetic testing, molecular diagnostics, it's just plain old medicine at this point. So that's the survey data about really, again, very descriptive, but what do real consumers, what do real physicians think about this area? And we had not seen any of this data published before, which is why we thought it was so important to put out there. So how about from a spending perspective? Well, again, this was even harder. Because of the lack of specificity in the coding, et cetera, we found it impossible. Our original design was to be much more specific about the spend. We couldn't do it. So what we did is we categorized it. We categorized it into very broad buckets, but infectious disease, cancer, and then inherited and other, and pharmacogenomics was in that space. And then we thought it was just useful because you do learn something about population, to do it by payer type, because that's who we are. We're in the commercial, Medicare, and Medicaid. Can you see it yet? Okay, so, well, here's the bottom line. So, first of all, the drum roll is that at UnitedHealth Care, between our book of businesses, and we serve about 34 million members in those three lines, we spent about $500 million in 2010. If we extrapolate that to the nation as a large, that was $5 billion. So that's the number. And again, that number is hard to find, but we did a lot of data digging, and two of my colleagues in the back, Jean DeSalle and Brantley Carlson, did the lion's share of the work, so thank you. That is the number. It is in Medicaid, it's off the roof in infectious diseases. In Medicare, what do you think it is? Cancer, right. And it's interesting because the volume is much higher in the infectious disease Medicaid, but the cost per test is very high in Medicare. And net across our book of business, it's about the same. It's a little higher in Medicaid and Medicare compared to commercial, but the volume of just people is so much higher in commercial. And another sort of interesting factoid is what percent was the inflation from 2008 to 9 to 10? 14%. 13 in commercial, 21 in Medicare. So again, as you think about the future and what it looks like, it sort of makes sense as more and more of us baby boomers are entering the Medicare market, and that's when the cancer years hit, all that sort of makes a lot of sense. Let's get that one. And then what does, oh, I'm still not up, right? Okay, the projections. Then why am I standing here? Yeah, you're right. The projections, so if we project that out to 2021 in a national spend, that number should be somewhere between 15 and $25 billion. Pretty big numbers. Small compared to the total healthcare spend, but who remembers the days when pharmaceuticals were a very small part of the spend, and today almost are where hospitalization is. And so, and what will push it either down or up is adoption. First, how quickly do the real physicians and real consumers adopt this technology? Number two, what are the reimbursement pressures going to be when we move from fee-for-service to more accountable care organizations, et cetera? You're going to see some cost pressures, and then the complexity of the tests that come out from an innovation perspective. We know when these new tests come out, they are more complex, they are harder, and of course they cost more. So in summary, bridging the gap, mind the gap. How do we mind the gap between caution and optimism? You really heard it all today. We have some protections for consumers. We need to make sure consumers really understand what that means, and of course we need to live up to them. We need decision support, loud and clear, both on the physician side and the consumer side. The evidence we need to build, we have to make sure that there's analytical validity, and as I was thinking about the article again from the UK group, is that biopsy validity? I don't know. And if you look at what the cost is, if we have to do the sequencing and we need to, even from a pathology perspective, slice the whole thing, the costs are going to go through the roof. So I don't think we know what the answer is. And we need to make it easier for real healthcare practitioners to stay up to date. I have a 17-year-old, and it's fascinating how high school science has changed. When he read the report, he actually understood a lot of the molecular. Now he happens to be very bright, but he really got it. And I thought, isn't that interesting? I graduated medical school in '91, and I think that this is really hard stuff. The younger generation, they're learning it now in high school, but we didn't, and we didn't learn much of it in medical school, at least in my age group. So we have to just recognize that, not be judgmental about it, but then develop the appropriate CMEs. And I think it'll be an interesting question for the boards. How are we going to introduce those questions gracefully to those board exams? Because we can have high failure rates, so, but I took my recertified 5 years ago, there were no questions. We'll see in 2 years whether it's back. Thank you so much.
gonna take one question, and it's Mark.
Yeah, what a huge surprise there. So the question I have is that, the economics to me are really interesting because, again, you add up a few billion here, a few billion there, and then you're talking about real money pretty soon. But the reality is that, as you say, in the context of the total medical spend, this is a tiny little fraction. So in some sense, even if we mind our P's and Q's and keep that $5 billion relatively stable through improved technologies, what we're promising is we're somehow going to bend the cost curve. And that's really about how we use the information. It's not about the technology. And I think that's a really important thing to focus, that if we're really going to promise that we're going to somehow change this, this cost, it's going to have to be in pharmacy and hospitalization and other things. Those are the deliverables that we're going to have to use this information to achieve. It's not that we're going to make our technologies cheaper.
Well, I think that's you're dead on, and this is actually just for the testing itself. So none of the stuff that goes around. We know in clinical medicine the lab drives 70% of all costs, through its subsequent decision making. So that's where I think the question gets interesting. But you're right. And if you look at the pharmacy world, if in the future right now we know that lots of people take expensive drugs that don't work. Right? If we knew exactly who they worked for, A, we could afford to spend more on said drug, but B, and we would have less side effects. I mean, the list goes on and on. But we have to make sure that we don't just develop the test and then not use the information. Even in something like oncology, our data suggests that sometimes when people get information that I should get chemo, I don't. And sometimes the exact opposite, and both are sort of scary situations, and we just have to make sure that it's in the aggregate. But I totally agree. Thank you.